There you are, everyone. Okay. So, has anyone got a question ready, or do you want us to share one that has already been submitted?
Those first.
Sam just indicated.
Yeah, hi. Sorry, can you hear me?
Yeah.
Yeah.
Yes.
Yes, hi. So I did actually send this question in, but I didn't think that I would be able to be here to actually talk it in person. So I've got diabetes, but I've also got cystic fibrosis. So I don't know if this is sort of because I've got cystic fibrosis that this happens or not, but I just thought I'd ask this question anyway. So I eat, say, around 5 o'clock at night, sort of like have some food like tea. I inject on a 1-to-1 ratio, and I've also got like a Libra sensor as well, which tracks my overnight blood sugars. Is it common for blood sugars just to automatically go sky high throughout the night, even if I've injected the right amount for the food? Because that's what it does for some reason, and I can't put my finger on it.
Right. Are you talking about the sugars overnight or just the first 3 hours? Okay.
Yeah,
Right. So, in that case, what happens here is that when you inject your insulin with the meals, it's a quick acting insulin that you're injecting. And it covers for the period for next 2 to 4 hours after your meals. The peak onset will be 1 hour to 2 hours of the injection. After that, the activity of the quick acting insulin wanes and disappears. Yeah, certainly by 4 to 6 hours, it's probably gone by then. So overnight, the sugars, the quick acting insulin is no longer in your system. Yeah. So the insulin that will be working overnight to control your sugars will be a basal insulin, the long acting insulin. Yeah. So I presume you're on the long acting insulin as well as the quick acting. Yeah. So if your sugars tends to go high overnight, let's say from bedtime to the following morning before breakfast, then what it tells you is that your background insulin cover overnight is not sufficient. So you may need to increase your background insulin for that matter. So which insulin do you use for your background cover?
Degludec.
Okay, so Degludec is once daily injections. And what time do you inject it?
In the morning, sort of like 8:30.
Okay, so if you inject 8 a.m., then you work for 24 hours till 8 a.m. following morning. So I guess what's happening here is that your Degludec cover overnight is not sufficient. So you may want to consider increasing Degludec dose, but usually we increase it small amounts, maybe 2 units each time, to minimize the risk of hypoglycemia. You say you got freestyle Libra, is that correct?
Yes, yeah, the sensor, yeah.
The sensor. And what does the profile show overnight? Does it rise progressively?
Yeah, within a couple of hours of going to sleep, it just starts to rise, and you're talking at least 15 or so.
Right. So, sometimes in the early hours of the morning, your hormones kick in, growth hormone, the cortisol, so forth, kick in, and that's it works against the insulin action. So it tends to raise your blood sugars. So what it means here, maybe you need to increase your Degludec dose a bit more, yeah, to cover the rise in your blood sugars overnight. Yeah, that's one thing. The other thing you can consider, maybe you want to inject a Degludec at a different time of the day, maybe later in the day, and see whether it makes any difference or not. Yeah. So there's few things you can play around it. I think the first thing to do is increase the background insulin cover overnight and see whether that will mitigate the problem that you mentioned. But certainly it's not due to your quick acting insulin, because overnight the quick acting insulin have disappeared from your system already. It's no longer there.
Cool, thank you.
Any more takers?
Can I just add, sorry, just a follow up if that's okay?
Yeah, sure.
Sorry. So does adrenaline actually just naturally spike the blood sugars as well? Because
Yes.
like when I wake up, it starts to alarm saying that it's starting to rise.
Yes, there's different hormones that antagonizes the action of insulin. So growth hormone, cortisol, adrenaline, noradrenaline. Yeah. So adrenaline and noradrenaline are hormones that is released from your system when your sugars goes low. It's one of the mechanisms in your body to react against hypoglycemia. Yeah. So when the sugar goes low, especially below 3.5, then you notice that your catecholamine levels like adrenaline starts to rise, and the reason is to mitigate the further fall in your blood sugars. So yes, so answer question, adrenaline increases the blood sugar in your blood, and that's a natural way to preempt or avoid the risk of hypoglycemia.
Okay, thank you.
I think that's a great question.
Yeah, it's a very practical question, and a lot of people found that problem. It's not just you, it's a very common issue. And it's just understanding about the, why the sugar's going up overnight, the reason behind it, and what insulin is working. I think, it's very important to know in each part of the day, which insulin you're taking that's working at the time to bring your sugars down. And that will make you understand which insulin to increase by, or which insulin to increase, especially in type 1 patients on basal bolus, whereby you have quick-acting insulin and background insulin. You need to tease out which one that you need to manipulate dose-wise. And the other thing people talk about Somogyi effect, yeah, whereby some people say that in the past, if your sugars are high in the morning, perhaps you may have a hypoglycemic episode overnight, let's say 3 or 4 a.m. in the morning. I think that kind of idea is no longer held to be true anymore. I think that's sort of been discarded, that Somogyi effect probably does not happen. If you ask the experts in hypoglycemia, that's what they'll tell you. So the most common reason why sugar is high in the morning is because the sugars are high overnight and it's rising, and you need more cover overnight, not because of hypo causing a rebound rise.
Yeah.
I think there's some questions that was emailed to me.
Yeah, I've got them.
You got them? Yeah, maybe you could sort of ask them. I'm not sure whether people who actually asked them is here.
I think, yeah, here's,
somebody
have you seen, is somebody asking now?
Somebody's putting a hand up.
I've got to ask them.
Hi, Doctor. Hi, guys.
Hi.
I don't know if you can, I've got a question, probably, I'm not sure if you can probably assist or just shed some light on it. It's random because I've got a son who's 14 years old, type 1 diabetes, since he's 5 years old. General care has been really good all of a sudden, and just all of a sudden he's been having like constant hypos, like hypos that will last literally, he'll have to keep treating every 20 minutes for even up to 3 hours. But then the next day he'll be fine with the same amount of insulin. It's just like randomly, and he'll have to treat a ridiculous amount of times. Any reason why that could be? He's usually his average night on Libre is quite good. It's not rising or decreasing. He'll work up fine, and then all of a sudden, just out of nowhere, he just gets these hypos, which just one after another, and he just doesn't get the glucose levels up.
Okay. First of all, how old is your son?
13, sorry.
13, okay. And the hypos, does it happen for a prolonged period of time, or just certain time and for a short period and then it disappears?
Yeah, that's it. It just suddenly, like this morning, he's at a school teacher training day. So he was at home. So he got up about 10 o'clock, a bit later. So he had a bit of a bigger snack in the evening. And glucose levels when he woke up was 6, wasn't dropping on, I think. Had his breakfast, what he normally has, and had insulin for it, which is on Nova Rapid. And then within an hour, he dropped low. But the amount of time we had to treat as hypo, he literally had like a just say a Lucozade Sport 500 milliliters, and then 300 milliliters of Lucozade. He's had a fun size Coke, Dextro gel, Skittles, and then it started increasing. But it was just a random one. It just
I mean, it's when you have recurrent hypos, usually the most common reason for hypoglycemia on insulin is mismatch of your insulin dose with your meals. Yeah.
Yep.
Or your background insulin is wrong. And the other thing that may affect is your activity level, physical activity, exercise. So if you physically active, the hypoglycemic risk is increased for the next 18 to 24 hours. Yeah, that's another factor. So it's usually food and activity. Yeah, so if you're looking at other things like medical conditions, so certain medical conditions can cause hypoglycemia, especially with type 1 diabetes, because it is associated with other autoimmune conditions like Addison's, for example, thyroid disorders, celiac.
Okay.
Yeah. So I think if the sugars has been stable and then suddenly it becomes a bit funny and causing lots of erratic glucose high and lows, then you do need to consider anything else has happened to cause that fluctuation in glucose stability. So I think first thing to do is look at lifestyle factors with diet and exercise and whether the insulin dose is given appropriately for the meals that your son is having. Yeah. I think next time when you sort of have these issues, look at the pattern of hypos. Does it happen certain time of the day, or is it any time of the day? And also look at his lifestyle, his activity. Yeah. Is he doing far more exercise the preceding day, for example? That's one thing to look at. I presume, he will have regular checkups for blood tests, and they'll check the thyroid function test and so forth. I presume his weight is increasing nicely and he's growing up nicely. Yeah.
Yeah, his weight's fine. His HbA1c has been really good for the last 6 months. It's just this was a real concern for us because it's not like him. He started saying, "Dad, I'm feeling really cold," and it's just random that obviously we joined this meeting about last week when I'd come across it, and then I'd thought it just had to be on today that it just happened. So we spoke to his diabetic team. They said see if the glucose levels increased, and they did by the afternoon. About 3-4 hours later, they did increase. But it was just one of them that we were really concerned about. How could it be? You've never had nothing like this. That it went on for so long, though. Usually, the hypo's treated and one treatment and it's fine. A maximum of 2 treatments and he's back to normal.
Yeah. One thing we can do is to do some blood tests to rule out thyroid disorders, adrenal disorders, and celiac, if that's not been done yet.
Okay.
Certainly, I would definitely consider that. So for Addison's, so basically where your adrenal gland is not working due to autoimmune destruction, that's seen in type 1 diabetes, and Addison's condition can lead to hypoglycemia. Yeah.
Okay.
Malabsorption with celiac disease can also cause that. Okay.
Okay.
And thyroid disorders can also cause that as well. So certainly, if anyone with type 1 diabetes having hypoglycemia, I would definitely rule out these conditions with blood tests, and that's easily done. Maybe the diabetes team has already done that. I do not know, but certainly it has to be excluded.
Okay. Yeah, we'll speak to them and make sure he gets a blood test for his thyroids to be checked.
Yeah, definitely. So Addison's, celiacs, and thyroid disorders.
Okay, cool.
Can I just, because I've got type 1, I'd be looking at reducing my basal for the next day, the next time I had it, to see if that helps.
Yeah, we could try that. Yeah, we could reduce his basal today and see how that goes.
Yeah. Give him a little break from it all as well.
Is it okay to just if we're concerned, is it okay to totally just remove the basal for a couple of days, or no, or is it best just to reduce it? What would you guys recommend?
I will not stop it, because basal insulin is the crucial insulin in type 1 diabetes to prevent diabetic ketoacidosis.
Exactly, yeah.
So you never stop your insulin, especially the basal insulin, because it's that insulin in the background that prevents ketogenesis and ketoacidosis from happening. Yeah.
Okay.
Stop your background insulin. You reduce it.
How much should you reduce it by? Because he's on quite a high amount of Traceba at the moment. He's
How
on about
how-
32 units in the evening.
Right. How low is the hypo when it happens?
Oh, 2.9, 3, 3.2s.
You can reduce it by 10%.
Okay.
Yeah, 10 to 20%. And see, whether that will, mitigate the risk of hypoglycemia. So minimum 10%, definitely.
Okay, yeah.
Up to 20% and see. It's a trial and error.
Yeah, definitely.
Because everybody responds differently to insulin dose adjustments. If hypos main concern, I'll just start at 10% and review over the next 24, 40 hours. If it still happens again, then I'll cut another 10% down.
Okay. Cool.
And with the Freestyle Libre, that's easily done now. And that's advantage having Freestyle Libre because you can see the trend of it happening.
Definitely we can, yeah. Thank you, Doctor. Appreciate that.
Thank you.
Thank you. Has anyone else got one lined up? Because we've got some written down.
Ask a question, please.
Yes.
Yeah, hi, my name is David Cantrell.
Hi.
I'm 62 years old. I was diagnosed with type 1 4 years ago. Been in good control generally, and I've recently been diagnosed with rheumatoid arthritis and osteoarthritis in some of my joints. Should I be taking extra precautions regarding COVID? And also, I had my knees drained on Monday afternoon with 2 steroid injections for prednisolone. My bloods have gone sky high since Monday evening right through until today. It's only today that I've managed to get it back in range.
Yeah. Are you on any medications for your rheumatoid arthritis?
Yes, I can't think of it. It's hydroxychloroquine, I think it is.
Right. Okay.
I've literally been on that for 3.5 weeks.
Yeah. So I think if you're on any medication that could suppress the immune system, then you're at higher risk of
Right.
problems, So, and certainly I would, take precautions about it.
Yep.
Because you're on medication that could increase the severity of infection of COVID.
Right, yeah.
Yeah. So I think the main ones are, immunosuppressive agents, because if your immune system is suppressed, then you're more at risk of infection of any kind.
Yeah.
And that includes viral infection like COVID. So I would play safe with that.
Right. Thank you. And just regarding blood control, I started off, obviously, I've got a Libre, so I've been monitoring literally just about every hour, a couple of hours in the evenings.
Yeah.
I was touching 20s, 22, so I started to increase my quick acting Nova Rapid by looking at the figure when I take my reading, carb counting on a 1-to-1 ratio, and then trying to work it back. If I was sort of 18, I want to get back down to 9, so I'd add 9 as a correction factor. Generally, it seems to have been working, but I've still dropped. I've dropped, then gone back high again. I think that's because the Nova Rapid's gone past the 4-hour limit.
Yeah.
I've now started increasing my background by 2 units over the last 2 nights, which I'm on Levemir.
Yeah.
Tonight is the first time I've got an 8.2 in sort of within 3 days.
Yeah.
So, is there any general guidelines that would assist in that process? Carry on as I am.
I think first of all is that in terms of the basal bolus, I think the first thing you do is to find out whether your background cover is adequate or not. Yeah.
Right.
And because if your foundation of your glucose is not there, is high, for example, it's going to be more difficult to control it. So first thing to do is look at your sugars in the morning first thing.
Yeah.
Because your pre-breakfast glucose value is the truly fasted glucose level, because you're not eating overnight. And if you get your sugars level right at the start of the day, then it becomes easier to manage your glucose for the rest of the day.
Right.
And you have a better idea which insulin to increase by as well. Yeah.
Yeah.
So in general, the first thing to do is to get your background insulin correct. So to do that, you need to get your pre-breakfast and also the pre-evening meal level down. Okay, the fasting levels. Once it's down, then you can now work on your quick acting ratios.
Yeah.
In general, if you're steroids, actually it's quite difficult to control it, because if especially potent steroids and methylprednisolone, and in general you need to increase both basal and quick acting insulin to control it. Right. And you may need to use corrective insulin dosing as well. You need to rescue insulin with your quick acting insulin.
Yeah.
So you may have your quick acting insulin routinely with the meals, but if your sugar is climbing high in between meals, let's say above 20, then you may need to give boluses of quick acting insulin to bring it down. That's
right.
what rescue insulin. Yeah.
Yeah.
And to do that, we start off by using the ratio of 1 unit of, let's say, Norapid or Humalog. We'll bring the blood glucose down by 3 millimoles per liter, 1 to 3.
Yeah.
Yeah. That ratio may change from one person to another. Especially on steroids, that may change as well. You may need more. Yeah, because what happens in steroids is that your body becomes more resistant to the action of insulin. Yeah,
right.
So you need more insulin to bring the sugar down than when you're not on steroids. But in general, we start with the formula of 1 unit of quick acting insulin lowers the blood glucose by 3 millimoles per liter.
Yeah.
So I think you need to sort of look at how much insulin you're needing to use to get your sugars in decent level. And then you may need to adjust that, your background insulin and your quick acting insulin accordingly. But certainly one starting point is try to get the start of the day, the blood sugars in the right level.
Yeah, thank you.
If you start at 12, 14, you're always catching up the rest of the day.
Yeah. Understand. Yeah. Thank you.
Thank you. I think that's another hand. This is Shukrat.
Yes. Hello. I'm
Hi.
sorry I joined late, so I'm not sure if my question has gone, but it's basically okay. I'm type 1. I've been type 1 for 17 years. I was diagnosed at 27. My issues are with, I wonder if I have some kind of insulin resistance, and it worries me because I seem to always need to add to my insulins. What you call rescue insulin, for instance, I'm almost always correcting every day. Typical example today, my fasting was quite good. It was within range. I had my background in the morning. I have 30 units Levemir in the morning, and then at night I have 40 units of Levemir. So everything was fine until I take my quick acting. I had my breakfast, and it was all within range. But then I've been sitting down most of today. For instance, I've been in meetings since morning, and then I just was about to come down to get something to eat, and then I noticed that probably in the last 30 minutes it had gone up, a sharp rise, about 12 from maybe 7 or 8.
Right. Okay.
So usually I might just be feeling ill, that prompts me to check. And then I see that it's so high. I haven't had anything to eat for more than 6 hours. So, you know, it worries me. This happens frequently. You know, I can't find any reason for the rises, but then I keep having to correct. And then I really can't do 1 to 3. It doesn't do anything. So if I'm correcting maybe 16 and I want to bring it down to 8, I would take maybe 10 or 12 units, and it probably still won't come down to 8. That's on one side. Another thing I've noticed is that I seem to have dawn phenomenon a lot. You know, I'm in range at night on a good day. I'm in range through the night, and then about 3 a.m., 4 a.m., it starts climbing. And no matter what I do, you know, I take correctives at that time, I won't see the effect for hours. So I will stay high for 2-3 hours. That happens in the morning.
Does it happen every morning?
I won't say every morning, but a lot of times, enough to cause me worry.
To answer your question, insulin resistance can happen in type 1 diabetes. Yeah, it is known to happen. You can get what we call metabolic syndrome in diabetes. So I think, you know, so for the dawn phenomenon, I think, you know, is you're on Levemir, isn't it? Am I right? Yeah.
Yes.
And what time do you inject the Levemir at night?
Okay, at night, usually about 9.
Okay.
And then after discussing with my nurse some time ago, she suggested I, you know, reduce the time so that there's an overlap. So I started doing the morning one earlier. So I do morning one about 6 in the morning.
Okay.
So that usually seems to balance it out if I was in range before.
Right. Okay. So you inject the morning insulin earlier. Is that right?
Yes.
Has that helped?
That's what I'm saying. If I was in range, usually the night before, that usually helps. And I stay in range, you know, all through the night, and I don't have high. But there are just some days, and I can't find any explanation for it. It just keeps shooting high.
Yeah. I mean, one option is to, you know, the nighttime insulin, Levemir, you may inject a bit later. That's one other option.
Okay.
To sort of, you know, because, yeah, sometimes if you inject a bit later, then it may prevent it from going higher later, early hours in the morning, a few hours later. Yeah, you want to sort of coincide the action a bit later in the evening injections, if you understand what I'm telling you. That's one way of doing it, but you don't want to sort of leave the gap too close or too far apart, depending what time you're looking at. Yeah, you want to keep about 10, maybe 10 hours difference between 2 injections. So normally in the morning, what time do you inject your Levemir?
About 6:30 a.m.
6:30 a.m. Okay. But you say that was brought earlier. Before that, you were injecting a bit later. Is that right?
Yeah, before that, I was injecting about 9.
9. Okay. So maybe you could inject your nighttime Levemir 10 or 11 p.m. bedtime. What time do you go to bed, first of all?
Latest 10.
10.
Yes.
Okay, that's early. Okay.
Yes, but then, you know, because I know I won't get a good sleep all through the night. I'm waking up to inject. I'm waking up to pee. So I'd rather go earlier.
Right. Okay. And what time do you wake up if you got 10 o'clock?
About 5:30.
Okay, so that's your pattern. Okay.
It's just said to this diabetic, what time do you go to bed? It's just 10 o'clock. I went, oh, wow, that is early.
That's early, yeah. Yes. How about the food or activity level? If you go high, is there any correlation with activity levels, for example? Were you less active in those days?
That's more confusing for me. I'm not very active. I know that because my work entails me, you know, I'm at the computer for hours most times during the day. Right. There was a day last week that I went out and, you know, I actually did well over 10,000 steps. So I would call that active for that day. You understand?
Yeah.
And then I didn't have anything to eat. And then I got home in the evening and my blood sugars were, straight up 15 going high. And I'm like, exercise is supposed to help you control your blood sugars. But for me, it keeps getting, and it sounds crazy, but then I have to take insulin to exercise. I have to take insulin to, but really I can't predict how much exercise I'm going to do. So I really wouldn't be taking insulin, when I'm going for a walk or when I know that I'll be out walking a lot. So,
yeah. Difficult one, that one, because usually activity brings the sugars lower, but for you it makes it go higher. Do you say
go high, and then hours later I might have a hypo? Hours later.
How many hours?
Sometimes I might have gone to bed maybe early the next morning.
Right.
It depends on the day in particular.
And when you exercise, were you doing intensive exercise?
No, this day I was just walking. So, I was out, I was walking, just walking. Nothing, wasn't vigorous activity, no.
Right. How about sugars in the day itself? Were they okay in the daytime? I know it's going up.
On that day?
Sorry?
You mean on that day that I had the highs after walking?
Yeah, if you're high, if you're going high, the dawn phenomenon, yeah, and you took your insulin injections at 6 o'clock in the morning, how about the rest of the day? Was the sugars better and in target?
Honestly, I haven't noticed any pattern. That's the difficulty for me. I can't seem to, notice a pattern and say, oh, this is how it happens. No, it doesn't follow one pattern.
Yeah.
But the issue with the dawn is I wish, I knew how to control it better, so that, as you said, of course, if you start your day in range, it puts you in good stead for a good day, you know. So already if I'm waking up with 15, 16, I already know I'm having a horrible day.
What is your HbA1c?
The last one was high.
How high?
It was about 66, but the ones before that was 55 or so.
55. And does your sugars fluctuate quite a bit then, from high to lows? Do you get wide fluctuation?
I get more highs.
More highs.
I get more highs, a lot more highs. Hypos are not very frequent.
Right. Okay. I mean, the other solution is insulin pumps. Yeah. Because with the problem with insulin injection, once injected, is there already, and you can't manipulate the amount of insulin going to your body. Yeah. So when you inject your depot in your, let's say 9 p.m., that's it, it's done. Okay. So if you're having problems getting your sugar under control, the benefit of insulin pumps is that the pumps infuses quick acting insulin like Humalog or Norapid in very small amounts each time, minute by minute. Okay, and the infusion rate can be adjusted, at any time of the day and night. Yeah. So if you have dawn phenomenon, for example, if your sugars are going high after a certain time, let's say 3 a.m. in the morning, for example, the beauty insulin pump is that you can program the basal infusion rate of the pump to ramp up just before 3 a.m. to counteract the rise in your sugars. Yeah, because
so
what it tells,
it gives your dose over time.
yes, you can increase the basal rate. So what it tells you, if you've got dawn phenomenon, then you need more insulin, let's say from 3 a.m. onwards, to control it. When you give yourself Levemir at 9 p.m., that's it, it's done. You can't do any more about it, right? Whereas if you're on insulin pumps, you can decide your basal insulin infusion rate at certain level, let's say from 9 p.m. to 3 a.m., for example, And then from 3 a.m. to, let's say, 7 a.m., you may need more insulin during the time. And with the insulin pumps, you can actually increase the basal insulin infusion rate for that period.
So does the pump do both basal and rapid?
Yes.
And rapid acting. Oh, okay.
Yeah. So what the pump does, it infuses quick-acting insulin, Levemir, Humalog or no rapid, either one.
Mm-hmm.
It infuses a small amount of insulin infusion every single minute throughout the day, 24/7. And the amount of insulin infusion that's been pumped into your body can be varied or changed from part of the day to next part of the day, depending on your activity. Yeah. And when you eat, then it will give a bolus of the quick-acting insulin to cover your meals.
Okay, with the pen, with the injection.
No, with the pump.
Oh, with the pump as well. Okay.
So the pump gives a constant background insulin infusion in between meals, and then it gives a bolus of insulin to cover the mealtime that you have. And the wave of the increase of insulin can be manipulated as well, depending on the kind of meals that you have. So it's more flexible.
For the bolus one, for instance, do you set, is it preset, or you decide as how much you get per meal?
You decide
Okay.
how much you get per meal. Everybody's different. They look at your pattern of your glucose. They'll manipulate the bolus profile of your pump to that will suit you. It also depends on what kind of meals you have as well, whether you have fatty content, high carbohydrate content, the kind of carbohydrate you have is a low GI, high GI index. So it's quite complicated. But the beauty of pump, it can be manipulated to fit the waveform of your meals, of your sugar rise, and it can be manipulated to control your background sugars in between meals and overnight as well. Okay, it's more flexible in terms of meeting the needs of the insulin that your body needs to control your sugars. Because we know the body sensitivity changes day to day, or even within the same day. So for some people, morning could be more resistant early hours of the morning. Some people that may not happen, for example. Okay,
What do you do about that resistance? It's just the doses that.
Yeah. I think it's very difficult to do anything about resistance. I mean, you want to reduce the insulin resistance. The key thing is to lose some weight, because weight loss has been shown to improve insulin sensitivity. Okay. Yeah, and that could help. I think exercise can help as well, because exercise can improve insulin sensitivity for at least a few hours post-exercise or during exercise itself. And that's why some people have hypoglycemia during exercise or after exercise. And that also depends on how intensive exercise is being done. Yeah. So exercise is a very loose term. You have to look at the intensity of the exercise, how long you do it, what kind of exercise you're doing as well. So it's quite a complicated subject by itself,
More complicated because there's some type of exercise that makes me go higher.
Yeah. So you're right. Some people exercise and notice sugars actually go higher, not low.
Yeah.
So for those people, when they exercise, the body pushes a lot of growth hormone, cortisol, adrenaline, that overpowers the insulin that you're giving yourself. And because of that, the sugars rises. Okay.
So the way to do that is the only thing you can do is to take insulin at that time.
Yeah. If it goes high, some people may actually correct just a tiny amount, to sort of don't make sure it doesn't go too high up. Yeah. And also depends how high the sugar goes up to as well. So, something you may want to consider is insulin pump. If you're really struggling to get the sugars under control with your basal bolus insulin injections, the next level up is insulin pump therapy.
Okay.
Yeah. Have you got Freestyle Libre, do you say?
Yes.
Yeah. So, with pumps, it's good because you've got Freestyle Libre as well. You've got the technology there. You could see with the Freestyle Libre, the waveform of the glucose excursions, and it can manipulate your insulin pump infusion, especially background infusion, accordingly to target those areas whereby part of day or night, whereby you need more insulin to control your sugars.
Okay. Okay.
So I think the next level for you is to consider a pump therapy, potentially.
All right. Then. Thank you very much.
Right. Right. I'm just looking at the questions that Lindsay has posted. Got a few there, is it? Let me scroll up. Right. What could you have eaten that may slow down the absorption of carbs? Right. Usually it's what you have with it. So protein and fat may retard it, may slow it down. Yeah, for some people. And also that depends on what kind of carbohydrate you have as well. So, you have a low GI index or low glycemic index carbohydrates, then the absorption of your glucose will be less. So the trickling of the glucose or the rise of glucose in the blood system is slower and not as high compared to high GI index. So it's quite a complicated question, actually. I think the answer is probably due to the kind of carbohydrate you have and also the co-ingredient you have with your carbs. So in particular, your fat content and sometimes the protein content, which may retard or slow down the absorption of the carbohydrate. Guidance on blood sugars and steroids. I think if you want to look at guidance, are you aware of the JBDS, the Joint British Diabetes Societies, which basically is involved in, formulating guidelines in managing type 1 diabetes on insulin. I think they have guidelines on steroids as well and sugars. Depends on whether you have type 1 or type 2 diabetes, and depending on the type you have, obviously for type 1 diabetes, you need to manipulate insulin dose. Yeah, you need usually more background and also quick acting insulin as well, especially when on steroid treatment. For type 2 diabetes, again, that depends on what agent you use, but usually we may give glycoside or we may give background insulin. Yeah, depends on what time the steroid is given. So if you're given the steroids in the morning, for example, let's say prednisolone, that's the most common steroids people use, usually it's taken in the morning. Therefore, for next few hours, you will notice your sugars will start to rise in the afternoon. Yeah. So if you're type 2 diabetes, then one solution is to take the glycoside dose in the morning with the steroids. Yeah, because glycoside works for next 8 to 10 hours. So that will coincide with the action of prednisolone to mitigate it. And if that doesn't work, then you may consider some medium-term background insulin like Humulin I, or Levemir that lasts about 10 hours. So it depends on the sugar profile, really. So the answer to your question is, it depends on type of diabetes. Type 1, obviously, insulin dose manipulation. Type 2, glycoside or insulin therapy that we use to control the sugars. The perfect diet to get into remission from type 2 diabetes. Yeah, I think the dietary manipulation has now become more important because of the direct study in 2017. We showed that you can cause type 2 diabetes to go to remission if you lose a certain amount of weight, and the weight you're looking at least 10, 15 kgs. Yeah. And in some people, you can put the sugars back to normal. In a direct study, they recruited people who are diagnosed within 6 years of type 2 diabetes, so fairly recently diagnosed. And the reason for that is because if you're fairly recently diagnosed, you still produce a decent amount of insulin from your own pancreas. Yeah. So when you lose the weight, your body weight goes down, your insulin sensitivity improves, and demand on your pancreas to produce insulin is less because there's less insulin resistance for the pancreas to overcome. So in some people, if you choose achieve certain amount of weight loss, then insulin sensitivity comes to a level whereby your pancreas is able to cope with it, yeah, and able to release the insulin that's sufficient to normalize the glucose for the new level of insulin sensitivity. Yeah, and I think that's, in the simplistic terms, I think that's how diabetes is going to remission. Okay, but you need to lose at least 10 kgs from the studies that's been shown so far. I think NHS England has rolled out the low-calorie diet program, as a pilot to see whether this diabetes remission can be achieved in real-life practice. Yeah, I think Sheffield is one of these centers that's been, recruited for that. But all means speak to your GP. I think if you're newly diagnosed type 2 or recently diagnosed type 2 diabetes, it's something you may want to consider enrolling yourself into and trying and see. But not everyone will respond to it. Okay, so like any treatment, the response to treatment is variable, depends on the person themselves. So unless you try it, you'll not know whether you respond to it. It's something to consider. But even you don't get them to remission, but we do know that if you have good diet, lose some weight, it helps and becomes a bit more easy to control your sugar level, even with your type 2 diabetes medications. So it's not, it's not lost really. I think you don't get too disappointed that there's diabetes is not going to remission, because not everyone does, but it may help to improve your control than what it was before. So it's a gain for that reason. We got an event about being active. Okay, that June 18, move more with diabetes. I think that's good. I think any physical activity is good. A lot of people think when you do physical activity, you need to be intensive in your exercise. It's not true at all. I think just move around and do things. Get your body moving, get the muscles working, because by doing that, it makes you feel better, it improves your general well-being, improves the fitness as well. And also over a period of time, it can improve insulin sensitivity. So it makes your body more responsive to insulin, whether it's produced by your own pancreas or given by insulin injections. So I think that's a good ethos to have, is to just keep moving and be active. Does insulin sensitivity decrease with age? And does exercise increase in sensitivity? So yes, exercise does increase insulin sensitivity because it increases blood flow to the muscles, and the absorption of insulin will be quicker, and the insulin action will be enhanced as well. So as people get older, unfortunately, people tend to gain weight as well in general. Okay, and also the beta cell function becomes lower in its function. So to answer that question, the first part, yes, it does decrease with age. I think it's probably predominantly due to the fact that we are probably exercising less due to a variety of conditions like joint problems, but also some patients, they also gain some weight as well, and that could lead to increased insulin resistance. Research and new technology for type 1 diabetes. I think technology is a big deal at the moment for type 1 diabetes world, with the CGMs, with the pumps, with the hybrid closed system, loop system, whereby basically you're going to have a pump that will infuse the correct amount of insulin depending on the sugar levels that's been detected. So it's a closed loop thing. Yeah, it's an artificial pancreas, so to speak. I think that's the research direction in type 1 diabetes at the moment. And with the technology, there's new pumps coming out with closed loops hybrid system in place. And also in terms of the technology for monitoring glucose, there's always new CGM things coming out as well, in terms of more facilities to monitor your sugars, alarm system and so forth, suspend features and so forth. But the end game here for type 1 diabetes technology is closed loop hybrid system, I suspect. ideally, ultimately. It's like making a pancreas artificial that works for you. How will diabetes tech be rolled out? I think the funding has already been made available by NHS England for pump therapy for CGM, and NICE has now, when it's published next month, for type 1 and type 2 diabetes, we are actually advocating more widespread use of CGM or flash, depending on patient's choice, for both types of diabetes. Yeah. So I think that will become more prevalent. I think the problem at the moment is the loopholes or hurdles, not loopholes, hurdles to jump through to qualify for a flash, to qualify for a CGM. I think what NICE is trying to do now is open the door more widely, in particular for type 1 diabetes patients, so that they have access to this technology that will help improve their control and their lives, and also reduce the diabetes stress that some people have. And for type 2, for the first time, NICE is actually advocating using flash CGM, first off, or real-time CGM if the price comes down to become more cost-effective. We are not excluding both. So when we say CGM in NICE, is either intermittently scanned ISCGM, which is flash, or RT, real-time CGM, which is Dexcom G6 or G7. So that's going to open the door to more people with type 2 diabetes. Have you seen the draft guidelines or draft guidelines for CGM for type 2s and type 1s? Have you seen them? It was out for consultation end of last year. So by all means, go to the NICE website and look at it. Yeah. We have already met in January to discuss the CGM guidelines, and that will be finalized and published end of March. So watch the space for that. What it means here is more people have access to technology to monitor sugars. There's a hand being raised.
Yeah, hi, Doctor. Just me, Zach, again. Just with regards to what you've said with CGM being for type 1 patients. Well, my son, he's on Freestyle Libra, and we have funded Dexcom himself because other area doesn't actually, he doesn't meet the criteria, or they don't actually give out Dexcom. So in March, are you saying the NICE guidelines are actually now changed, have they, or?
Yes, I think the updated NICE guidance will make technology more accessible for patients with type 1 diabetes.
Okay, cool. We'll bring that up with our consultant when we speak to him in a few months' time, actually.
Yes, so, certain by April onwards, you should be looking at new guidance.
Well, that's great, yeah, because in all honesty, if you're looking at Dexcom, will be great for him, or even, I think there's Freestyle Libra Freeze came out in some countries. Yeah. I don't think it's out in the UK as of yet. But like I said, it just saves, especially with a child with type 1 diabetes, constantly texting him, son, scan yourself. It's but if you've got a reading there, it just gives you a peace of mind and makes it a lot easier. So that's great news, that is. So thanks for that.
No worries. Right, so going to the list, will GP be able to prescribe Libras for people? I don't think so at the moment, because when you look at technology with CGM and flash, you do need a level of expertise to be able to interpret the data. And it can be quite complicated because there's a lot of data being presented, and you need to know how to interpret the data according to the insulin injections that you're giving yourself. So answer is no. I think it's going to be in the remit of specialist teams, diabetes teams, because we have the expertise, we have access to technology, and we deal with it every single day. You need to do it every single day to be good at it. And I don't think primary care have time for that. I don't think they will want to take on this role anyway, given their other responsibilities. Right, JBDS, where to look for the guidance on, okay. So what you can do, just Google, Mr. Google, that's the best place to go to, JBDS, or join British Diabetes Society. they will come straight to the website, and on the website, it will tell you all the guidelines have been published so far, and you should find it there. Or you can just Google JBDS steroid diabetes and see what comes up. Right. So another question, what is the relationship between the bladder and diabetes? Who asked the question? Bladder and diabetes. Well, the one that can think of is urine infection. Yeah, because anyone with diabetes, they're more prone to having UTIs or urine infection or thrush. Yeah. That's what I can think of. But in terms of, and the other thing, association is complications. So if you've got autoimmune neuropathy, so we got neuropathy can be peripheral or central. Central is what we call autonomic. So the autonomic will control certain organs of the bladder, your gut, for example. So if you've got autonomic neuropathy, then your bowel, the bladder function and your bowel function might be a bit dysfunctional, and you may not be able to control your bladder function too well, and usually become atonic. What it means that your bladder becomes lazy. It does not work well to contract and push out the urine. So when it's more lazy, then what happens there is that urine tends to accumulate in the bladder itself, and that can lead to urine infection with time. So I guess the relationship I can think of is the complication of diabetes with autonomic neuropathy affecting bladder function. And the other one is sugar control, whereby if your sugar control is not so good, then you're more prone to having bladder infection. Right, I've come to the end of the questions. Any more from the list that you have, Lindsay, that I can address? Let me look. Type 1 and rheumatoid. There's another question. If NICE agrees that everyone with type 1 diabetes have a Libra and more people becomes eligible for pumps, will more than one consultant become responsible for those people? Answer is probably yes. Because I think when the number of people on pumps and CGM or both increases, then, you know, more diabetes consultants will need to be familiar with these technologies. And again, depends on where you work, which centers you belong to. So certain centers, this kind of expertise may be focused on one or two individuals. Yeah. Whereas other centers, that responsibility may be shared more widely among the diabetes consultants, especially in smaller DGHs, yeah, because they've got less number of consultants. So in Sheffield, we tend to have certain consultants dealing with type 1 CGM and technology here. I think there are 2 or 3 consultants, my colleagues, who does that. Yeah. So answer the question, yes, it's probably more consultant be involved in the future moving forward. We talked about the dawn phenomenon already.
I've got one.
Okay. Can there be variations between different batches of insulin? Type 2 on human eye, 1 injection per day around 6 p.m., half an hour before the meal in the evening. I keep record of blood sugar readings and the amount of insulin taken. When I change to new tube of insulin, my blood sugar reading the next morning is quite different. Yeah, I think different batches of insulin may have some differences in insulin action. It depends on the manufactured insulin for that batch of insulin you get. But in general, it should not vary too much, really, from one batch to another, because it shouldn't, strict speed shouldn't happen. I guess if it shows that your, first of all, the sugars will vary, and the variation in insulin in blood sugar level may not be just strictly down to the insulin that you use, really. It could be due to how you feel that day, whether you feel okay or depends on your physical activity that day, your food intake that day, you know. So there's other factors that may play to make the variable insulin sugars that you see from day to day. And we know from our experience, even though you inject the same amount of insulin each day, the blood sugar profile will change from day to day anyway, because the absorption of insulin may vary from day to day from where you inject. Yeah. So for the insulin to work, you inject the subcutaneous tissue, it forms a pool, and then the insulin is slowly absorbed in your system. When you change to another site, again, that may change again the absorption. So it's not straightforward to sort of look at the insulin batch or insulin type that you use, and you expect the sugars to be similar, even though the dose you use is the same. But we know the action of insulin does vary day to day, or even within the same day for the same person, due to other factors we discussed. So JBDS 08, there you are. Shirley has found the guideline for JBDS. Is there any progress towards a cure? Not yet. I'm not sure there's any cure in sight. I think for type 1 is the islet cell transplantation. There's no cure for type 2 yet that I know of. So the islet cell transplantation, in some people, you know, they stop the insulin altogether and control the sugars nicely. I think the challenge here is that, you know, to maintain the longevity of those islets functioning optimally for a long, long time. So there's no cure. I think there's hope in terms of doing without the insulin with islet cell transplantation. But we know that this is not the perfect treatment as yet, because in some people, the islets do fail after several years. Yeah. And also, if you're on islet cells transplantation, you are on immunosuppressive agents as well. So you need to be mindful of the side effects of the agents that you use to maintain the viability of the islet cells. Have you seen a difference in diabetes contributing throughout the pandemic? Yes, I think what we have seen is there's more admission with high sugars, uncontrolled diabetes, and diabetic ketoacidosis. Yeah, I think that's been shown in England in recent publication last few months, whereby the admission rate for DK has increased in type 2 diabetes, you know, and also more uncontrolled diabetes occurring as well in type 2 diabetes, and also to some degree type 1. I think it's because with the pandemic, people don't see the GPs, you know, the human face-to-face interaction is curtailed, and the contact with healthcare professionals is reduced, and lifestyle changed. Yeah, so there's less monitoring, less scrutiny of blood glucose, and because of that, sugars rise, becomes uncontrolled, and they fall over the cliff and presents with DKA or uncontrolled hypoglycemia. And also a lot of cases of new diabetes diagnosis has been missed because there's less monitoring being done by GPs, less blood tests being done. So it's a combination of factors here. So answer your question, yes, there's definitely worsened control during the pandemic. So next one is Lonnie grandson who plays with type 1 diabetes, who plays rugby and football. Why is it that his levels can vary so much each time he plays? Sometimes levels go up during a game, at times goes down, sometimes stays stable, so it's difficult to predict how he'll be. Yeah, I think we discussed this earlier on, whereby, you know, the response to exercise varies. I guess it depends on the intensity that one does. So, and if you do very intensive exercise, if you exert more in the football match or rugby game, the adrenaline, noradrenaline, cortisol, growth hormone levels may go high in those situations. So in that case, you know, sugars may go up in those levels. And if it goes down, you know, depends on whether he's less active in those games whereby he had hypos. But certainly, the hypoglycemia can happen post-exercise. Yeah, so a lot of people think of the glycemic excursion during the game itself, but I think the main danger is actually after the game, the next 18, 24 hours post-exercise, whereby that's the danger period where hypoglycemia may happen. So yeah, I think the fluctuation will be, I guess, will be dependent on the intensity of exercise that he did, even if it be the same game of football or rugby match. There's a hand up from David.
Yeah, it's just a fairly simple question from an earlier discussion, actually. My background is Levermere. Tend to normally inject my mornings around about 8 o'clock, but then in the evening I'm injecting any time from, say, 10 o'clock or 11 o'clock. Would I be better off doing an 8 o'clock morning, 8 o'clock PM, or that type of arrangement, so that you're spacing it out more regular?
It depends on your sugar levels.
Right.
If you're on a regime that you're on now and the sugar levels is good on that regime, you don't change it.
Right.
You carry on. We only change it if your current regimen is not working out for you.
Right. Understand.
And remember, the duration action of insulin varies from one person to another as well. So the studies you see, they quote 10 to 12 hours, you know, that's the average. And in some people, it may last longer. In some people, it may last shorter.
Right.
Okay.
Understand.
So, you know, it's not strictly time of 10 to 12 hours. I think you inject what you're doing now and assess your glycemic control. If your sugar control is good or decent on your current regimen, you don't need to do anything differently.
Right. Thank you.
The next question here, has COVID created more new diagnoses of diabetes? Certainly there's new diagnosis, that's certainly from the paper in Lancet Diabetes Endocrinology, I think published 2-3 months ago, looking at DKA. I think they found that there's more uncontrolled diabetes emissions for newly diagnosed type 2s, you know. Is it new, or is it more diagnoses being made because people are, you know, are getting less active? I'm not sure the answer to the question, to be honest. But we do see, you know, people coming through with uncontrolled diabetes. One thing that could happen is that people may have pre-diabetes, for example. Okay, so they're not normal, but they're pre-diabetes. So HbA1c between 42 to 47, and then because of the pandemic, you know, people are less active, so they gain weight. We know people have gained weight in the pandemic, and coupled by the fact that they see less of the GPs, so the weight gain in some people may have tipped the balance and caused them to go from pre-diabetes to over diabetes. You know, so increased food intake and less exercise. Yeah, and some people catch COVID, and with COVID infection, it's a very stressful situation, and some people who are already at risk of getting diabetes, that again unveils that tendency to diabetes and become over diabetes. So maybe there's increased number of people presenting with new diabetes in the pandemic, particularly with type 2 diabetes, I suspect, from the Lancet paper. How can people with type 1 diabetes get pumps? So I think there's criteria to go through from pump therapy, and that will probably maybe slight variation from one area to another, but usually it's type 1 diabetes only for pump therapy. So to qualify, you need to have gone through DAPHNE training or some structured education training. So you need to know sick day rules, carbohydrate accounting, and so forth. And you need to on basal bolus regimen and try your best to optimize the basal bolus regimen to control sugars. If despite that, you're still having problems in getting sugars to target, especially poor control, and you'll have complications which may be progressing, or you may have troublesome repeated hypoglycemia that's troubling you and affecting lifestyle. So those criteria will be looked at for pump therapy next level. Okay, so certainly Sheffield is polycontrolled diabetes or troublesome recurrent hypoglycemia despite best efforts with MDI and after structure education on basal bolus. So that's the criteria that we use in Sheffield. And I think that will be fairly similar across the UK. Okay, what else? Do you want a 5-minute break? Yes, I think that'd be nice. I have a 5-minute break now and you can talk about your event in June. I get the hint.
No, it's not a hint. It's just that it's been
No,
non-stop.
I know, it'd be non-stop. I'm pleased to have a couple now. Okay.
So I've just put this on. So does anyone want a little break now? If anyone wants a little break, just have one. But we're putting on this event in June, which will be quite close to the railway station, and we'll be looking at all things around being more active, so managing blood sugars, and that will be for people with type 1 and type 2. Different things that you can do, the science behind it, but presented in an interesting way. It's not going to be over our heads. And exercise, if you're disabled or you've got a sedentary job, how you can get the benefits of exercise. And there's going to be a special session for children and teenagers in the morning and the afternoon, and free lunch, free event, really good speakers, and talking about cycling. Well, the cycling one might just be about getting people together, but we're hoping we'll have an elite cyclist there. Can anyone think of anything else? Frank and Pusher and David, particularly, Shirley.
Is there going to be some dancing, Lindsay?
Oh yeah, City Limits have said that they'll come and do dancing at lunchtime, and that the whole thing about that is showing that you don't necessarily need trainers to be a bit more active. But I like Radio Sheffield on because everything they play I just think is really dancey. So they do a lot of kitchen dancing. Yeah, so there'll be music and dancing, good lunch, there'll be a prayer room, and what else? There'll be breaks. There might be some seated dance if anyone would like to try that. Really good speakers.
Who are the speakers?
Parth Narendran has given in and said that he'll come. So he's an expert in type 1, managing your blood sugars when you've got type 1. Who else? Professor Thomas Yates from Leicester, who he's just all over diabetes and blood sugars and exercise. So really good at supporting people with type 2 to get the benefits from it. And really good at supporting people with disabilities.
Yeah, Ollie Hart.
Yeah, GP Ollie Hart. The dietitians are going to do a thing about nutrition and exercise with diabetes, and we'll be looking at motivation. What else? So it's only February, we've got 4 months. There'll be cycling, so adults who haven't cycled for years or who've never cycled, there'll be a thing about getting on your bike and confidently. what else? And for the youngsters would be doing things about getting to know other people, so getting parents together and getting the kids together. So that'll be about making friends, confidence building, as well as expert information, but quite a lot about confidence. Yeah, and people with type 2 who've got into remission through losing weight and being more active. And look, I think there's about the links between if you've got a disability or if you're in pain, that impedes you can impede you being active, but it can therefore also make you more at risk of type 2. So we'll be looking at that and looking at how people can get into remission even if they're disadvantaged. Has anyone got any questions about all this?
How often is it quite a popular event? Do people attend? Patients?
Well, we've only done it once before, and that was January 2020, and that was popular. Yeah, it was popular. People have got really good memories of it. And I think this time we've started the planning earlier and we've got more people involved. So I think we're going to be, what we've learned from last time will go into this. Professor Heller has said he'll be the MC for the day, and we're going to have a raffle, a really good raffle, which he's very fond of. Yeah.
Good. Where's it held? Is it Ponds Forge? Or?
Most likely at Ponds Forge, yeah. Yeah.
It'd be good. I think I think a lot of people ask for exercise, so I think this would be a great event to ask the experts here.
Yeah.
Why sugars go up and down or erratic? What's the factors underlying it or driving it? Oh, Shirley has a hand up.
Yes, we've got. It's in conjunction with Move More Month.
Oh yeah.
So we thought that if we held it in that month, then it would encourage people to move more, and we can also link in with those as well. So we're hopefully I'm trying to organise somebody from the sports referral, so that people can know what it is to, a GP refers them to spas.
Yeah.
Good.
And I'm going to do a little talk on how I got back into remission and how I didn't do it with physical exercise. I did it because I do Tai Chi, and that helped me.
Excellent. Yeah, it's good to share experiences.
Yeah.
It's, because I think it's very powerful, and people can relate to that.
Yeah.
Jim.
Right.
Question.
Yeah.
Hi, Brenda.
Yeah. Dr. Song, you were saying earlier on that if you're very active, it can affect your blood sugars even the day after. Does that work the other way around? If you have a very inactive day, can that affect your blood sugars the day after?
When some people notice that, for example, I'm just trying to think, people who work in, and when weekdays and weekends, for example. So I think what people found is that when they're working, the sugars are generally a bit lower. And then when they are less active on the weekends, they notice sugars a bit higher. So I guess answer is yes, it can go the other way around, whereby you're less active, sugars tends to go higher because your body is less sensitive to insulin that you're taking.
But I was just asking about whether it can happen like even as much as the day after, because somebody was asking about all of a sudden, you know, you're going around 3 or 4, you know, most of the week you're fine, and all of a sudden, blood glucose, no matter how much insulin, it just won't come down again. And I'm just wondering whether that could be that. And in my situation, you know, if you're not going to work, you don't really notice a pattern because you don't really think. You only think to yourself, well, what was I doing that day? Don't think as far as, well, what did I do the day before? So just wonder if that could perhaps a thing to look out for. What did I do yesterday?
Yeah, I mean, certainly, you know, I can sort of relate to my patients, the people who, you know, when they change their activity are people who are still working, and then they have a break in the weekend. And they did say, you know, when they're less active, more sedentary, so to speak, their sugars were higher in the weekends.
We'd expect that on the day, but you wouldn't necessarily, I wouldn't have necessarily expected it that it can affect it. You know, if you have a very inactive day and the next day you'd go to be your usual active self or usually inactive, but whether the day before's lack of activity can affect the next day.
I think that depends on the person as well. You know, it can do, I guess. You know, I think here is, I think the individual variation in response to lack of activity might be different from one person to another. So some people may be more sensitive, whereby they're less active in the next few hours, my sugars may go higher. And some people
you'd expect that.
Yeah. So it varies a lot. The same thing happens with hypoglycemia. So some people may go low soon after, or some people may go low a few hours later, you know. So there's no way of predicting of how your body responds.
Okay.
Right. What else? So I think there was a question. What is the connection between diabetes, cholesterol, and high blood pressure? I think usually there's more, I think, you know, there's more relevant type 2 diabetes. I guess with type 1 diabetes can happen as well. I suspect it's due to what we call insulin resistance. Yeah. So when you have this insulin resistance, then it causes a lot of metabolic abnormality, and one of them is diabetes. The other one is risk cholesterol of certain types, like high triglyceride and low HDL, and the other one is high blood pressure. So the underlying driving factor here is insulin resistance, overweight or obesity. Yeah, that's why people who are overweight, obese get diabetes. Then they tend to clustering of risk factors of diabetes, cholesterol, and blood pressure control, blood pressure problem. Yeah, more in type 2 diabetes, less so in type 1. But we know type 1, even though it's autoimmune disease, type 1 can also, people can get overweight, obese. And when that happens, then this connection may occur as well. What else? Type 1 meetup. Research on Fitbit, no idea about that one. I mean, do people use the Fitbit and counting the steps these days? Do you monitor the activity? Is that commonly used now?
I do.
Yeah.
Yeah.
Certainly, you know, it's a good way to monitor. I think when you want to sort of increase your physical activity, I think it's good to sort of quantify it objectively. And I think the simplest way now is to count the number of steps you have done for that day. Yeah. So it gives an idea how much you've done that day, and you can compare day to day as well, you know. So I think, you know, I think when you do exercises, I think it's good to quantify the intensiveness or the extensiveness of your activity to perform. And the simplest way, I mean, for me personally, is steps. So when I walk, when I work at the Northern General, you know, I do 8,000 steps a day, you know. When off the walls or in the weekends, I do far less. You know, you could sort of can see how much less activity you're doing in those different periods. And that could sort of make you think a bit more as well and focus on your activity lifestyle. You got a hand up, Shirley.
Yes, that's how I lost my weight. I had a Fitbit, and I also used Move More as well. because at that time they had to move more months, and they had a Steel City Challenge. So it was Sheffield United against Sheffield Wednesday. So how many steps were accumulated? They won, and then my niece got a Fitbit, my daughter got a Fitbit, and we had a bit of a competition going on, and it worked. And I still use it now. I do the Active 10, so I set myself 30 minutes of brisk walking. So that charts that for you, and also it tells you when to stand up, when to move about. So it's quite good for that.
Yeah, I think it's just another example how technology can help to manage and improve diabetes treatment or management. You know, I think technology is going to be more and more prominent in years to come in both type 1 and type 2s. And there's no doubt that, you know, it helps to focus the mind, and how also helps to quantify. It's good to have data, because with data you could know where you are with your exercise, sugar levels, so forth, and you can use the data to improve things as well. So I think technology definitely is going to be part of diabetes treatment and management in years to come. I think more and more people will get used to technology as well with time. It's just a matter of getting used to it, familiar with it, you know, and it's not difficult. It's just getting used to, and, you know, making the steps, the initial move to learn about the technology. And once you learn it, you know, it becomes easy.
And you just don't use it for steps as well. You can do it for running, not that I run, but you can also do it for various activities such as swimming. You can log any dance, anything, and it just adds it up. And then it'll chart, you'll get a chart for every day of the week. And then you'll tell you how you can set your steps. You can do as little as 2,000 up to whatever you want to do. And you're in control of that. So, you know, that's one thing that it's good for. But I mean, technology as well. I use apps to log my meds to tell me when to take them.
Yes.
It tells me when to take, you know, to do take my bloods. So, and then it'll chart that for me, and you can print it off. You can take that in when you have a review. So it's, you know, blood pressure, it's all done.
Do you use any particular app?
Yes, I use My Therapy. So and I also use OneDrop.
Right.
So you can also put in your meds as well. So it'll tell you when to, you know, remind you when to take it, and then you can then tell it that you've taken it.
Right. Okay.
So that's quite good. And also, I was on a first aid course, and they were asking if anybody got the medication on the phone, and I said yes, I have. So it was showing you how the emergency services could log in without knowing your login details to see what medication you're on. So, you know, that was also very interesting, because you think it's secure, but all they need to do is just put emergency and just press on it, and it brings everything up.
I think with the apps, I think there are quite a lot of them out there, isn't it? And it's a matter of choosing one that works for you. I think that's the challenge, you know. I think if you're not into apps, first of all, and you try learn to use apps, it can be quite confusing. So maybe, you know, if you've got a patient group ever, you can discuss about it, chat about it, give some idea about what kind of functionality that you want to have in the app to make it if useful for your day-to-day activity. Maybe something the Sheffield group here can organize. I think apps is important. My worry here is there's so many apps out there, and people get confused which app to use. And some people may not use apps that's appropriate for what they want or suitable for what they want. So maybe somebody who uses them a lot and they know what's out there, they can maybe guide other people what kind of function they need to look for that will suit them. Yeah. And some people you have too much information, it becomes a problem as well. You know,
we did have somebody come to a meeting and explain about technology, and it went on to things such as like taking a photograph of what you were eating, and it worked out how many calories there was.
Okay.
And you know, so it is, yeah, it's finding out what's out there and what's the best for you.
I think Sam has his hand up.
Sorry, yes. I've just thought of a question. It's something that I saw in the news probably a good couple of months ago, and it's to do with scientists have created some sort of little small disc that can fit inside the human body. I think it's at trials at the minute, but it actually starts to replicate insulin. I don't know if you've heard about that. So it starts to produce insulin in the body, so therefore you no longer have to, the theory is you no longer have to inject.
Right. I haven't heard about that. So it produces insulin, do you say, or releases insulin?
I think it produces insulin. So it's basically it's a, I don't know if it was in the trials or if it was still theoretical, but it was actually on the news in like a science little section.
Okay. Right. No, I haven't seen that. I'm sorry. The ones I know clinically used is just islet cell transplantation, but we got, as I said, got limitations. Maybe they're looking different ways now to give insulin in a more normal way to control the sugars. I think the whole idea about islet transplantation is that with islets, they will behave like a normal islet in the recipient, and hopefully that will improve sugar control and negate the need for insulin. In some patients, actually, for type 1 patients, they actually came off insulin. Yeah. So I think the challenge now is to actually have sort of improvement or technology that will actually replicate that, you know, in more reliable form. With any islets or human organs, it may fail with time because it's a foreign material. So your body will naturally try to destroy it. Yeah. It's a defense mechanism. That's why you need to suppress the immune response for that reason. Yeah. And in some patients, it may work for many years. In some patients, it fails. So it's not perfect technology, perfect treatment yet. It's got issues. So I think, I'm sure the scientists are looking at different ways to give insulin in a normal way, but in a different manner. I think that's what this research is probably looking at.
Could they get around that, around the foreign body bit by taking their own stem cells or using raw material kind of thing?
Yeah, I think to negate or mitigate the autoimmune response of, the body destroying the foreign body is to use own stem cells, because the body will recognize it as its own and therefore will not try to destroy it. You're right.
Yeah. Cool. Thank you.
Kamil Amaki, right. So who's Kamil Amaki? Who's that?
He's a young man who's got type 1, and he spoke to the group last year about tech. So he'll find apps that anyone could get use from, but he'll say why he thinks they're particularly good for people with diabetes. But he also trials things that are for people with diabetes, and says what he thinks of them.
Okay.
David here, he follows Camille and looks at his films, watches his films.
Okay, gosh.
I can't see. Oh yeah, David's there, but he might be stroking the dog or something. Who knows?
I just put a link up to his YouTube channel, Nerdabetic on YouTube.
Well done.
He's just reviewed the latest Libra, hasn't he? Libra 3.
Oh yes.
So
is it on the market yet?
No, he got one given to him from a friend in Germany where it is in circulation already. So yeah, he likes it, the size of it, and the way it takes measurements every minute rather than every 5 minutes that a Dexcom would do. But he says it's only Apple phone only at the moment, so you can't use it on an Android device. So it's a bit limited in its app usage and things.
Is it real time? Is it behaving like real time CGM now? The Libre 3?
Yes. Although, there's another problem with it in that he said that there's inaccurate readings to begin with, and sort of some error in the error bars in the range of measurements at the start, first day, and then maybe there as it's running out as well at day 10 or something. So there's some issues that have not yet been completely give great confidence versus his normal Dexcom.
Right. Yeah, I think it's transmitting real-time sugar levels. So I think that's what I understand Libre 3 to be. It's like more like a real RT-CGM, similar to Dexcom, I think. Yeah, the thing is with the technology is so fast moving, you know, and sometimes you need to really on the ball to keep on track of what's happening. Yeah, and also the price changes as well. So, you know, it's very important to keep track because the price will make it more affordable or less, depending where you are. You know, I think the pricing will be crucial, but with time moving on, you know, moving forward, I think the price might come down with time. You know, it might become more affordable, and the new devices might become more competitive in pricing as well. So, but keep your eyes on the technology because it's so fast moving, and you know, it's very difficult to keep track unless you're really interested in this field. You know, for both patients.
It's the power of the NHS spend, isn't it? For I don't know how many thousands of diabetes patients they're going to buy a Libre for, sort of thing. That the leverage that they must have on the company must be, you know, name your price almost.
Yes, I'm not sure. I'm just wondering whether they negotiate a good price for NHS use. I don't know how they work on it. But certainly, when it comes to NICE guidance, it's all about. I think if you look at the wording, you know, we keep it open-ended for the technology because we know probably in the future CGMs will become less expensive, maybe, and it becomes less expensive. Then it becomes more cost effective, and then it should be used more. Yeah, I think I think that's sort of the wording around type 2s, also type 1s as well. So it all down to pricing. But we know CGM, we kept it very open-ended because we can't specify certain type of CGM because it will change again in the next 12 months. So, you know, it's a fast-moving field, and I hope it'll be more accessible to more people in the future with the cost becoming more competitive. And more companies are producing this kind of devices anyway now. I think Shukrat has a hand up.
Yes, sorry, just a quick one. I'll just appreciate if you talk a bit about the link between sleep and blood sugars.
Gosh, sleep and blood sugars. What did you ask the question? Is any remit behind that? Any angle?
Well, yeah, because for instance, I noticed that one of the reasons why I normally sleep early, but you know, once a while, maybe I'm trying to stay up to read a book or something, my blood sugars start going up. It's almost like clockwork. Once it's past 9:30, my blood sugar starts going up. So even if I wasn't ready to sleep, I'll just stop everything I'm doing and go to bed. You know, so I was just wondering, and then if I stay, you know, maybe weekends, if I sleep in, I notice, you know, changes in the blood sugars as well. So I'm not sure if it's the sleep, the timing, or what. I don't know.
I guess the weekend if you sleep in, then you know you're not as active as the weekdays when not sleeping in. Maybe that's the reason why your sugar is a bit different then. But if you talk about the normal sleep, I can't think of any. The one that come off is the sleep apnea and type 2 diabetes. That's where the sleeping abnormality occurs, so type 2 and OSA, what called sleep apnea, obstructive sleep apnea, tends to go hand in hand because of the weight issue. That could affect sugars, I guess, if the OSA is not well controlled. But sleep per se, I'm afraid I do not know the answer to the question you're asking. I just do not know enough about sleep. I'm sure there's a link, but I do not know the answer to the question at the moment. I need to look it up.
Okay, thank you. There's a really good book called Why We Sleep, which we had as a raffle prize. And the author's Matthew something, but I can't remember his name, but Shirley, I bet Shirley's looking it up already. So it's called Why We Sleep. And I don't think it looks at diabetes directly, but there'll be loads of things in it that make sense, I think.
Thanks, Cindy. I'll look out for that. Thanks.
I think sleep is one area whereby more and more research is being done. I think it's a very complicated physiological phenomenon, I guess, and it's where your brain shuts down and rests. Your body have a rest, but whether it have any impact on diabetes, I do not know. Certainly, you've talked about diabetes and sleep. This is a period by severe hypoglycemia tend to happen. Most of the severe hypos occurs at night or nocturnally overnight. So, and a lot of people have hypos without them knowing it. And I think that's where technology will become very useful here, like CGM or flash, whereby they can actually detect those low sugars overnight without patients waking up or knowing about it. I think that's a great advantage of technology in this area.
Yeah, I think so.
Shift work and night, research, I heard about that as well. What else?
I found it.
So the other thing is the type 2 diabetes guideline has come out 2 days ago on the 15th. So read about it. The type 2 diabetes pharmacotherapy. So are people aware of that?
No.
So basically the NICE guidance have come out and we are changing a lot. I think for type 2 diabetes is a major shift from previous guidelines in the history of NICE for type 2. So as you know, in NICE guidance for type 2 diabetes is usually A, B, C, D. Start with metformin. If it doesn't work, maybe think of next agent. If that doesn't work, think of next agent. So what we have done now is that if you've got type 2 diabetes with certain conditions, so if you've got any kidney disease or heart disease or heart failure, then you should start metformin with a SGLT2 inhibitor at the time of diagnosis or at around the time of diagnosis. And the reason for doing that is not just lower the sugars, but mainly is to give the cardiovascular renal benefit that this compound confers for type 2 patients. The problem with the stepwise progression for treatment escalation is treatment inertia. We know in primary care, the review may not be happening on time and escalation treatment may not happening on time as well. So for example, there's research been shown that treatment inertia can last up to 7 years, which is quite surprising and shocking to some degree before any escalation in treatment is undertaken in primary care. So you're losing time all the way through, whereby you lose opportunity to improve your sugar control, you lose the opportunity to give medication that could be beneficial for heart and kidneys or both. So because of that issue, I think NICE has recommended that if you're newly diagnosed, start metformin and SGLT2 inhibitors. If you got heart, kidney problems, or if you're deemed to be at high risk of getting this condition. So if you got type 2 diabetes and one other risk factor, which is basically obesity, high blood pressure, cholesterol problems, smoking, and family history of premature cardiovascular disease, then should be considered for this medication. And the other major feature is young type 2s. Okay, so people who are diagnosed with type 2 diabetes below age 40. And in Sheffield, between 18 to 39 years of age, young adults, type 2 diabetes is now the major type in Sheffield, not type 1. So the latest data from CCG shows that 53% of patients with diabetes between 18 and 39 have type 2 diabetes. 47% type 1 diabetes. So it's a big deal now. And we are trying to actually improve the care of young people with type 2 diabetes in this city. Yeah, I'm leading on that. And NICE have actually got this caveat now: if you're age under 40, you should be considered for this medication if you got these additional risk factors present. Okay, so it's a game changer. Actually, for the first time, young type 2s has appeared in the UK guideline. And for the first time, we are advocating using dual therapy usage at diagnosis. It's a huge shift from before. Yeah. So have a read of the new type 2 guideline that's published 2 days ago. I think make your friends aware, family, relatives, loved ones aware of it, because don't miss out on this, because it's done for a very good reason. It's to protect the heart and protect the kidney and prolong lives. Right. Any more questions at all?
I've got one. I just wondered whether you'd like to do a small feature on that for our March news brief.
Right. Oh, okay. You mean the NICE guidance?
Yeah. Well, on that is so game changing, because that's a really good way of getting information out, and we send it to a lot of people who work with people who've got type 2.
Okay, yeah, I can write a small draft, a small piece, because I'm working with Jenny Stevenson, Sean Murray, and the IT team now, to sort of kickstart the type 2, young type 2s. I think the NICE guidance has now given the cue to actually do it, because it's now official. Yeah. Young type 2 should be the focus, as well as the usual type 2. Yes, I can do something about that, and it actually also will raise a profile and awareness as well of new changes in type 2 treatment and the young type 2 diabetes. Now, BMJ will be publishing an article on the summary guideline for type 2 diabetes. Do people look at BMJ, by the way, the journal? No, okay, right, okay.
It's because unless you're an academic, you haven't got access to an academic library, and it's awful.
The one thing good about BMJ, I'm a co-author, by the way, with a NICE team, okay, and 2 other committee members. It's written in a way that's understandable, it's easily understood by lay people as well, especially the learning points.
Sounds great.
Look at,
you can't see it.
Yeah, look at the learning points. I think one of the sections is what's new in this guideline. Yeah. So I think it'd be quite sort of daunting, but at least you get an idea, the shift. Like, for example, you're using lifetime risk for young type 2s. Yeah. And then, a lot of people use Q risking, but Q risk actually is not valid for people under 40.
Yeah.
Okay. So under 40, there's no way of gauging what's the risk of getting cardiovascular event, And if you're young, in your 20s, 30s, you're not looking next 10 years, which is what QRIS is doing. You're looking next 50 years. It's a lifetime risk, okay? And And how do you define high lifetime risk? Very simple. You add up the number of risk factors that you have. And that's been published in New England Journal paper 10 years ago. A nice graph looking at 0 risk factors, 1 or 2 or more risk factors, and the lifetime risk goes up the more risk factors you have. It's common sense, yeah. And young type 2s, I was quite shocked when I saw the data from CCG in August last year. I said, really? 53% type 2s? Because young adults, we always talk of type 1.
Yeah.
You know, I was quite shocked with that. And it's actually opened my eyes as well. Okay. So I think look for the space. I think that's exciting. I think for diabetes, I think it's an exciting development with the type 2 pharmacotherapy that's just released. I think there's excitement for CGM technology in type 1 and type 2 diabetes as well. That's going to come out end of March. And also there's excitement in terms of how type 1 diabetes should be diagnosed. That again, will be coming out at the same time as CGM, whereby we're going to advocate using antibody testing as a routine to diagnose type 1 diabetes. At present time, it's not recommended, but we managed to get it through. It's going to be a routine test. So you suspect any person you suspect have type 1 diabetes, you should be checking type 1 diabetes autoantibodies as a routine. And if you're still uncertain, then we recommend you should consider using C-peptide with glucose testing. That's a new shift as well. So it's good new developments coming through in the next few weeks. So watch the space. I think, look out for the NICE guidance. I think NICE is very good in writing the piece for professionals, doctors and nurses, but also for lay people, for patients. Yeah. So read that because it actually explains well. Because people are involved in NICE, you can see how they work. They work from high level, data driven to patient level, whereby they make it easily understandable so that the message don't get missed here. So watch the space. I think we type 2 guidelines, the patient aid is published as well, if I remember correctly. So look for that.
Thank you.
Yes. And the same thing for CGMs and whatnot.
Right, Brenda, come on, last question, this one.
Yes.
Time for bed.
Yeah, could you please send us a link for that BMJ, and could you find out for us if we can access it or not, and if possible, could you do a quick summary of that as you are the other one, because it's a bit unfortunate if we can't get it.
Yeah, I hope it will be published. I think it will be because we're going to publish 2 articles, one on CGM and type 2 diabetes. I'm on the type 2 diabetes article. So once it's published, what I'll do, I download the PDF copy of the paper and then send it to Lindsay.
Thank you.
Circulate.
Thank you. Thank you, Dr. Sam.
Yeah,
no worries.
you.
I'll do the same for the CGM article as well.
Yeah, I put the nice one in the chat.
Yes, the type 2 guidelines, yes.
Yes, yeah.
And 28, yes, that's right.
Yeah, and it comes up as a chart, and it sort of maps what's happening.
Correct, yeah.
Yeah.
I must admit, it can be quite confusing actually when I look at it. Oh, you need to know you got to play with it and then sort of get used to the pathway, so to speak. But a lot of what has gone to it is the amount of work that goes behind to publish what we have now is humongous. But there's more work coming out because we had a lot of criticisms from stakeholders that we're not promoting GLP-1 agonists higher up in the treatment algorithm. It still remains a 4th line. And the main reason, actually the only reason for why it remains a 4th line is cost effectiveness. Yeah. The data for cardiorenal benefit is far more stronger and consistent across the different drugs in the SGLT2 class of drugs, whereas GLP-1 agonist is much more heterogeneous. Some drugs are effective, some are less effective, right? So that's why when they did the cost effectiveness analysis, these SGLT inhibitors came up tops, which was surprising to me. And that's why we're able to recommend metformin along with SGLT inhibitors at diagnosis as dual therapy. That's the reason why we got it, because of strength of the data, strength, the consistency of the data, and the cost of the drug. Those three were less good for GLP-1 agonists. But NICE is going to do more analysis now because this analysis is mainly on CVOT trials, cardiovascular outcome trials. And for GLP-1 agonists, we acknowledge that there's added benefits of weight loss. That's the main reason I use GLP-1 agonists, weight loss. Reduction in HbA1c without the risk of hypoglycemia. So this added benefit, apart from CVOT benefit for certain GLP-1 agonists, will be looked at more extensive review now. And that may change the positioning of the GLP-1 agonists in the future. And that's explained on the BMJ article when it's published.
Thank you. Thank you very much.
Thank you very much. So yes, it's been another exciting and riveting meeting with you, Dr. Song.
Thank you. I'm
Yes,
pleased
that's some
that,
good questions, everybody. Some really good answers. So thank you for coming, and hopefully see you soon.
Yes, thank you, and nice to see you guys.
Thank you very much.
Nice to see
good
you.
work.
Thank you.
Thank you.
So right, everybody, thank you for coming along. I hope your questions have been answered. But if you do have any other questions, just send them in to us, and we'll forward them on and see what we can do for you.
Yeah.
So I've just had a little notification on my phone that I've got to take my medication, so I'm off now.
Thank you. Bye, everyone.
Bye, everyone.
Bye,
Okay.
everyone.
Yeah, thank you.
Thank you.